I would like to thank AIOS at the outset for giving us an opportunity to present our work. I am Dr. Parth, the final resident at Shankar Nethralaya, and I'll be presenting a case of measles retinopathy, which was a diagnostic and a therapeutic dilemma for us. Viral retinitis is an important site-threatening infectious disease of the retina. Commonly implicated organisms include the herpes group of viruses. It can occur both in immunocompromised as well as immunocompetent patients. We report an unusual case of bilaterally rapidly progressing measles retinopathy in a vaccinated 14-year-old girl. The girl presented to us with the visual acuity of counting fingers 1 meter and less than N36 in the left eye and 6/6 N6 in the right eye. The color fundus photo of the right eye shows normal posterior pole. Left eye shows area of retinitis involving the fovea temporally with satellite lesions along the inferior temporal arcade. Suspecting viral retinitis, an AC tap was done for herpes, CMV, and varicella, which eventually came out to be negative. And because macula was involved, she was given intravitreal foscarnet injection. IV methylprednisolone 500 mg 3 doses and tablet acyclovir was started. Following treatment, lesions in the left eye improved and visual acuity improved up to 636. She presented to us 3 weeks later with diminution of vision in the right eye, in spite of being on oral steroids and acyclovir, with a similar patch of retinitis seen along the inferior temporal arcade, sparing the fovea this time in the right eye, which showed leakage of dye on fundus fluorescein angiography. The left eye showed healing by scarring. Serology for HIV, hepatitis B and C, and syphilis and toxoplasma was negative. AC tap was done for the right eye for viruses, which was negative. The right eye vision rapidly deteriorated to 1/60 and less than N36 with disc edema, along with rapidly progressing areas of necrotizing retinitis. Vision in the left eye remained stable. She presented to us 4 weeks later with vision dropping to PL positive, PR inaccurate with dense vitritis, along with hazy retinal view. USD B scan showed an inferior localized shallow retinal detachment. SWEPS OCT imaging of the left eye showed foveal thinning, along with intact retinal pigment epithelium. As retinitis in both eyes was similar at presentation, she was started on IV acyclovir along with oral and topical steroids. She started developing neurological symptoms like sleeplessness. Based on the symptoms, we suspected subacute sclerosing panencephalitis, and antibody titer was done for measles. The serum IgG levels showed levels of more than 300 arbitrary units per ml, whereas the normal value is less than 16 units. History of complete vaccination up to the age was 9 months was given by the parents along with the booster dose. MRI was done to rule out neurological regions, which showed optic neuritis, but without any brain parenchymal lesions. Electroencephalogram was normal. A diagnosis of measles maculopathy with optic neuritis was made. CSF analysis was deferred by the neurologist because of lack of further behavioral symptoms, as well as a normal EEG. Acyclovir was stopped and patient was kept on oral steroids. This is the final fundus photo showing areas of retinal detachment and a moth-eaten appearance of the retina of the left eye with areas of scarring. Measles is a single-stranded RNA virus. Ocular manifestations range from gamut from anterior segment to the posterior segment, but most characteristic is necrotizing retinitis, which usually starts at the macula. SSP is a progressive neurological disorder. It starts with behavioral changes. Ocular involvement occurs in about 50% of the cases and may precede neurological symptoms by several weeks or months. There is no specific treatment for measles retinopathy, but corticosteroids have to be given. In cases of SSP, neurologists advocate giving of inosine pranovex tablet along with intrathecal interferon alpha injection. Similar case reports have shown macular retinitis as an early manifestation of SSP. To conclude, measles is a rare but an important cause of acute retinitis and can lead to blinding retinopathy and fulminant life-threatening condition of SSP. It must be kept as a differential diagnosis in a suspected case of viral retinitis, especially in a young immunocompetent adult, even if vaccination is complete. And prompt referral by an ophthalmologist to a neurologist in time will aid in early targeted therapy and may be life-saving. Thank you for patient listening.
Questions for Dr. Parth?
Very, very nice case. And did you do AC tap? But I think vitreous tap was not done.
No, sir. Vitreous tap was not done. Anterior chamber tap was done, sir.
Right, right. Very interesting. And could we have done anything else, in this particular case?
Sir, we had actually done all the battery of investigations, sir. Even the routine blood investigations. Yes, sir.
Retrospectively thinking, now if you have to manage such a case, what would you do differently?
Probably.
Did you get my question?
Yes, sir. Yes, sir. I got the question.
Yes. Now, if you see such a case, how will you do things differently so that you can manage it, without vision loss?
maybe sir get the titers done early if at all in case, or start. We already gave the patients an intravitreal foscarnet also, suspecting areas of retinal necrosis in both the eyes. So the right eye received 2 doses and the left eye received 1 dose per se. But measles was a thing that probably wouldn't come as your first diagnosis when you say a case of retinal necrosis. Your diagnosis tends to veer towards the herpes group of viruses as well as.
You were thinking of ARN also, I think, in between, you know.
Yes, sir, because the picture and the lesion showed characteristics of acute retinal retinoschisis in both eyes, sir.
Sure, very nice. I think you should publish it. So
Yes,
it's worth a publication.
thank you, sir.
Thank you.
Thank you, sir.
Good presentation. I just have one question. Like,
yes, sir.
Other eye involvement, what you had seen,
Yes,
what was the frequency that you see in other publications, like similar reports?
Sir, the frequency is not mentioned because there is no particular case series, but there are only isolated case reports, sir. So generally it is seen in both the eyes. There is sequential involvement of one eye and then the second eye is involved. But certain cases have progressed on to SSP, whereas certain have stayed.
And
Yes, sir.